Thanks, Dr. Lang, for this nice introduction, and thank you for organizers for inviting me to this meeting and to this exciting celebration, I would say, because you're quite successful in starting the autologous stem cell transplant project, which is usually the start before you go for allogeneic, and probably this is the next step, or before you go for certification or accreditation by JC and all these things. So I was asked to give you a presentation. I was a bit concerned because in the beginning in my invitation it was only autologous stem cell transplantation, but in the second letter and then I saw it was allogeneic and autologous, so I moved all the slides, and then I saw I have 30 minutes. I just checked the program now, it's only 20 minutes, so I will speed up because I was planned actually for 30 minutes, so I apologize if I'm a bit delayed. So these are my conflict of interest. So this is actually the story of multiple myeloma, and this ended here in 2013. Actually, if you are involved in multiple myeloma, you know that in 2017 there's a huge progress in having new drugs, exciting drugs, also in Bortezomib inhibitors, IMiDs, but also antibodies are developed, and more recently also CAR T cells are entering the field of multiple myeloma. So because when the autologous stem cell transplantation started actually in 2018, and the allo was actually more or less the same time, there was not a lot of treatment. There was only the melphalan in conventional dose, or later on the VAD regimen. But in 2013, when Bortezomib introduced in the practice, it is a lot of drugs which are now available, and this is in the scientific community always a question we have to deal with. So if there is something new, we really have to think, is it still the proper treatment of our patients? So therefore in allogeneic stem cell transplantation we have, as you know, autologous and allogeneic, but if we specifically focus on multiple myeloma, you can see that within EBMT, this is a European registry of all transplantations, so you can see nearly 10,000 autologous stem cell transplantations are performed yearly in European countries and reported to the registry, while in allogenic stem cell transplantation it's much less, so it's not a common indication, it's around about 600 only. And here you can see the main indication for autologous stem cell transplantation within EBMT, but the same is worldwide, also in the CIBMTR registry is multiple myeloma, so nearly 50% of the transplant are performed in patients with multiple myeloma, followed by the lymphoma, by the non-Hodgkin lymphoma, or by the Hodgkin's disease. If you look, and this is based actually on two randomized studies, one was from the IFM 90, the other was from the MRC. A couple of years later, you can see this was also now nearly 20 years ago, where the conventional treatment arm, this was VID, VAD actually, was worse than the transplant, and this was the same in the British group as well in the French study. But what you can see on this survival curve, I hope you can see this and this, so you can see that there's still a step down of the survival curve, suggesting even if the survival is better than conventional treatment, it's not curative. In other words, the majority of the patient will relapse after autologous stem cell transplantation. If we look to allogenic stem cell transplantation, you can see it's completely different. So it's mainly acute myeloid leukemia or acute lymphoblastic leukemia, which accounts more for 2/3 of the patients who received an allograft in Europe, and now increasing numbers of MDS or myeloproliferative disorders, while CML, you can see, which was the main indication in about 15 years ago, is really going down. And if we look for multiple myeloma, this is, where's multiple myeloma, this is here, or plasma cell disorders, you can see, in contrast to autologous, so the part of the myeloma patient who received allo is quite small, even if you should consider that multiple myeloma is the most frequent malignant hematological disease in patients. So the reason why allogenic is performed is mainly due to, in contrast to autologous, where the stem cells you are using are only of supportive measurements. So the stem cells itself doesn't have any therapeutic effect, is in contrast in allogenic. So the main therapeutic effect is based on the stem cells, mainly on They included T cells, so the immune system of the donor, which can cause then this graft versus leukemia, or in specific multiple myeloma as a graft versus myeloma effect. However, the main reason why this transplant is not performed so frequently are the therapy-related morbidity and mortality, mainly caused by graft versus host disease, which probably is caused by the same T cells as the graft versus myeloma effect. And the data why multiple myeloma is transplanted allogenic is due to this early study from 1990 by Gösta Garton. And here you can see that you have in the beginning a high mortality, but at the end it seems to be, because here's a plateau, so at least it is suggested that allogenic stem cell transplantation is a potential curative treatment option in contrast to the autologous stem cell transplantation. So allogenic, these are European data. You can see one is allogenic stem cell transplantation for multiple myeloma performed. And you can see this registry started in 1990 and ended up in 2012. And you can see upfront allo is actually only 12%. Then the so-called tandem auto allo approach is now, the hype was actually in 2003, 2004, is now about 19% of all the transplant. And you can see the majority, more than 60% of allogenic stem cell transplantation in multiple myeloma is now performed in a more advanced disease, so mainly when patient relapse after 1 or 2 autografts. This just to see the results of allogenic stem cell transplantation in the registry. This is nearly 5,000 patients, and here you can see if you do the allo transplant upfront, either as a single allo or auto allo, you can see you ended up at 10 years with progression-free survival of about 40%. But if you do the transplant later on in relapse patient, after first relapse, you can see you ended up with 10 years with a progression-free survival of 25%. If you do the transplant even later on, beyond the second line, you can see then the progression-free survival after 10 years is only 10%. Okay, coming back now more to autologous, because this is a major topic of this lecture, is when we discuss autologous stem cell transplantation in contrast to other disease, it becomes more and more a package nowadays. So you cannot, so usually we have the induction chemotherapy or induction therapy, then we have the transplant or the high-dose chemotherapy, but we have to discuss also the consolidation today, and we have to discuss maintenance therapy. So starting with induction, so I mentioned earlier that in the late 90s we had only this VAD regimen, and then when the first proteasome inhibitors came into the market, this is the Bortezomib, the Velcade, you can see this was one of the first trial by the French study. You can see there was a higher remission rate, complete remission, near complete remission, very good partial remission, and overall remission, and this led to that the Bortezomib then become a standard treatment option or treatment course for newly diagnosed multiple myeloma patient as induction chemotherapy. This is from the Hoven, this is the Dutch and the German trial, and they compared the VAD to PAD. This is an anthracycline and this is Bortezomib, and you can nicely see that the progression-free survival is significantly better than the VAD, classical VAD regimen. The overall survival was better, but this was only borderline significant. So to make a long story short, there are so-called meta-analyses comparing all the studies which have been done by Bortezomib-based induction chemotherapy, and you can nicely see here the yellow line, this is the Bortezomib-based induction, whereas the others, you can see there is a benefit in the progression-free survival, but also in regarding overall survival. And just because I mentioned it earlier, there are so many new drugs available for multiple myeloma that even there is a lot of interest in increasing patients' remission status before transplantation by starting first with this 2-drug combination and then 3-drug combination, and more recently also so-called 4-drug combination. And even you have heard this, so the Velcade-based, Velcade Thalidomide or Velcade cyclophosphamide, or also in the US it's more Velcade Revlimid-based induction chemotherapy. This is currently the standard for induction therapy. So usually this is used for 4 to 6 cycles before you go for the stem cell transplant. And more recently, more active drugs. So maybe you know this Aspire study, which was in relapsed patient with carfilzomib. This is the second generation proteasome inhibitor in combination with Revlimid. You can see a high rate of so-called stringent CR or molecular CR with MAD monitoring by NGS or by flow. You can see a high number of these patients achieved already a very good deep remission before they go to the transplant. And also, if you look to what is currently in the study, so this is a typical study from the IFM and the HOVON. This is the Dutch and the French group, and you can see here that they increased from a 3-drug combination now to 4-drug combination, including also effective antibodies. So this is the daratumumab, and we will see how this will improve the survival at the end. So in other words, currently in 2018, it's a standard to use at least a 3-drug combination as induction therapy, and there is a discussion whether this should be done only 4 cycles or whether you should go for 6 cycles and look when you have the best response. So currently in our institution, our recommendation if you monitor those patients very closely, you have some very nice clues nowadays with the free light chain assay, for instance, where you can always see whether an additional cycles improves the depth of the remission, and then go for the transplant when the maximum response is achieved. So then we have the high-dose chemotherapy. So the question today, and this is also a question, do we really need high-dose therapy with these novel agents if we get this very good remission? And actually a couple of trials, so I will show you 2 trials which has been published so far. This is a trial from Antonio Palombo, published 3 years ago now. All these 400 patients received an lenalidomide-based induction, and then they were randomized only to the consolidation consisting of melphalan, prednisone, and lenalidomide for 6 cycles. This was the consolidation, and the other 200 patients received tandem melphalan followed by autologous stem cell support. So the main primary endpoint was progression-free survival, and you can see there was a second randomization. This was a maintenance therapy with lenalidomide, 10 milligram for 3 weeks, but the maintenance until treatment progress. So this is the main message. So you can see here, this is the survival curve, the red one, this is the best curve, and this is if you do the high-dose therapy plus maintenance therapy. And this is the high dose without maintenance therapy, but you can also see this other curve. This is the conventional therapy with maintenance therapy. So if you do conventional therapy with maintenance therapy, you achieve the same results as high-dose therapy without maintenance therapy. And the worst was the normal, so the conventional therapy without any maintenance therapy. So this is the progression-free survival. So at the overall survival, there was no survival benefit so far. And this you can often see in clinical studies in multiple myeloma because these patients live quite long after relapsing. So to see overall survival, you need a longer follow-up in these patients. There's another study from the French together with the American. This is the Dana-Farber Cancer Institute. The study started in 2009. Actually, the main question was in this study whether you should do the transplant upfront, so either induction chemotherapy, here is the typical American regimen with Revlimid, Velcade, and dexamethasone, and then do the transplant followed by consolidation and maintenance therapy, or you should go for just keep the Revlimid, Velcade until progress and maintenance therapy and do the transplant at time of relapse. So the French has published their part. And interesting what you can see, though, on the left side, this is the Revlimid, Velcade, dexamethasone arm. This is the transplant group. And if you focus here, this is a complete remission. You can see significantly higher in the transplant arm. Also, the very good partial remission, significantly higher. And especially, and I come to this later, the minimal residual disease status was also significantly higher in the transplant group in contrast to the Revlimid, Velcade arm. This where the corresponding figure was also published recently in the New England. You can see the progression-free survival was significantly better in the transplant arm, while the overall survival, due to the follow-up, as I mentioned before, did not reach statistical significance. There's a third study which I would like to mention to you. This is a large European intergroup. This is the European Myeloma Network. And you can see they included more than 1,000 patients, and they have different questions. So the first question they would like to answer is that after an induction chemotherapy based on Velcade, cyclophosphamide, and dexamethasone, whether patients should go for transplantation, autologous, or they should receive only a consolidation with Velcade, melphalan, prednisone based. And so this is from the first randomization. You can see here is the stem cell transplant, there is a conventional therapy, and if you go down here to the response, you can see there's a significant higher remission rate, very good partial remission or better in the transplant arm than in the VMP arm. And if you look to the overall median progression-free survival, you can see also significant favor for the autologous arm. And if you look for standard risk cytogenetic or high risk cytogenetic, so high risk cytogenetic in multiple myeloma is here defined as deletion 17p or translocation 414, you can see that the median survival is also in favor for the transplant arm in the standard and in the high risk cytogenetic. So another problem which came is that multiple myeloma is, as other hematological malignancies, is more a disease of older patients. So the median age of diagnosis is between 65 and 70 years of age. And when we look to the EBMT database, you can see that the median age of transplant in the last 20 years increased from 52 now to nearly 60 years of age. So we were interested because all the studies I mentioned before were done only in patients up to the age of 65. So we looked in EBMT database, so this is more than 50,000 patients. What happened in the last years with these so-called older patients? So until the age of 65, so this were the standard, which is based on this randomized study, so this is evidence-based. You can see here a substantial number, so between 2006 and 2010, nearly 4,000 patients were transplanted. And you should consider this is not evidence-based because the study was only until 65. But you can see that over the years, so the blue one is from 1991 to 1995, then we have 1996 to 2000 in green, and in red is from 2001 to 2005, and then 2006 to 2010. And you can nicely see that the survival in this patient is increasing every time period, showing either the selection of the patient is better, or even there is a learning curve from the centers that they learn how to deal with the problems and to learn to handle the problems and the side effects properly. And interestingly, if you look even to these patients who are more than 70 years of age, and you can see we found even more than 1,000 patients in the registry, also there you can see a dramatic improve over time in these patients. So the message from this slide or from this study is there's actually no upper age limit in treating patients with multiple myeloma with autologous stem cell transplantation. It's more dependent on the constitutional symptoms, on comorbidities. So you can select patients even if they are more than 70 years for an autograft. So in the past, usually after high-dose chemotherapy, I don't know what is your procedure here in your country. Most of the centers stop treatment, but therefore I would like to in the last couple of minutes to focus a bit on consolidation and maintenance therapy, because this becomes more and more important. So consolidation, maybe you know this from other disease like acute lymphoblastic leukemia or other disease. Consolidation is actually a short course of therapy which is designed to intensify and to deepen the response following the initial therapy. And there are some studies in multiple myeloma how you can consolidate the autograft, and this is for instance by drug using Bortezomib or Thalidomide or combination of these, or you can do a second transplant either as a tandem transplant with autologous, or you can do the second transplant with an allograft, so using this auto-allo approach. I'll give you some data. What about the results using consolidation? So there are some studies, so these are both from the French and this is from the Nordic group. They compared the VTD versus TD, this is Thalidomide, Velcade, dexamethasone versus Thalidomide, dexamethasone, or Velcade versus nothing. And you can see in both trials that in the majority of the patients, so they could upgrade their remission, so they achieved a near or complete remission if you add some consolidation. And this resulted in an improved progression-free survival, not in an overall survival, but in a progression-free survival. And interestingly, if you look more carefully, and this is a study from the Italians, they used the VTD 4 cycles, and they looked specifically whether you can achieve molecular remission. So molecular remission is probably the deepest remission you can achieve, and they increased the likelihood of being in molecular remission from 3 to 18%. And you can see this was also translated in an improved progression-free survival. So interesting, this large study I mentioned before, this European myeloma network, they investigated also whether you should consolidate maybe with a second autograft. Now this is just the VRD consolidation from this group, so you can see also in this study that the consolidation with 2 cycles VRD was in favor to non-consolidation regarding progression-free survival, and here you can see the hazard ratio. The other option to consolidate beyond drugs is to use a second stem cell transplantation. So we heard previously that here also in your country, in Kaunas, you have done so-called tandem transplantation, or you can do what I mentioned before, do an allo reduced intensity transplant. So we come back to this study, and this study also compared here in this arm also a tandem transplantation. And interestingly, though, that they found that a second transplantation, you can see here, is in favor of a single transplantation, and this resulted also in an improved progression-free survival. But the story is not so clear as it is for a single high-dose therapy. So this is, for instance, another study. This is a very large study performed in the US. This is a EBMT CTN network, so-called Stamina trial. It is not published so far, but presented at ASH 1 year ago. And they randomized patients after 1 high-dose chemotherapy either to no consolidation, followed by lenalidomide maintenance, VRD 4 cycles and lenalidomide maintenance, or giving a second autograft, a tandem autograft, followed by lenalidomide maintenance. And what you can see here, the compliance rate was not as good for the tandem transplantation, as you can see here. More than 32% refused a second transplant, even if they were adjusted for a second one. And if you look to the probability of progression-free survival, overall survival, or progression, you can see there was actually no difference between the consolidation with RRV, a second autograft, or only with a single autograft. So, and this is also reflected in the European data. You can see that the numbers of single transplantation is steadily increasing, while the numbers of tandem transplantation is going a bit down. So currently the recommendation for tandem transplantation is hard to say. So there is some recommendation to use tandem, for instance, in high-risk cytogenetics, or 414 translocation or 70p translocation. And the other option is, there is a recent meta-analysis, is probably if you don't have a very good remission, non-complete remission, after the first autograft, then it's an option to do a second autograft as a tandem. You can also do an allograft, an allo-reduced intensity. The idea is that you distinguish the so-called allograft by high-dose therapy and immunotherapy by autologous stem cell transplantation, and 3 months later you started with an allograft, reduced intensity, and maybe you can add some adoptive immunotherapy. So in this specific status or disease, is a lot of studies are done or still ongoing. Here there is a so-called not a strict randomization depending on donor availability. So all of the studies compared autologous, and if there was a sibling, they go for an auto-allo reduced intensity arm, mainly based on 2-grade TBI, but others use melphalan 140. And you can see only the German study included unrelated donors, the others included only HLA identical sibling. So what you can see here is in red is always if something is significant. So the therapy-related mortality is significantly higher actually in all of the trials, you can see, but it's not so high. So even after allograft, so it's not 30%, so it's between 10 and 16%. While autologous, it was between 4 and 5%, 3 and 5%. So it was significantly lower in the autograft. However, in 3 of the studies, the complete remission was higher after allografting, and the disease-free survival was significant in favor in 2 studies for allo. and the overall survival also in 2 studies. The other studies didn't show any benefit for the allograft, and therefore for the currently in 2018 it is recommended to do this only in clinical trials or in some individual cases with, I would say, very young myeloma patient, less than 55, with poor cytogenetic, especially p53. So this is the European data. So by Göster-Garton, this auto-allo approach with a long-term follow-up. This study was in favor for the auto-allo, as you can see here. Also in the survival, it was in favor. You can see at 5 years, survival was 65 to 58% in the auto-only arm. So regarding consolidation, you have also a lot of options. So last I came to maintenance therapy. So maintenance therapy was actually in the past investigated first with interferon, but this has no effect, so I will spare this out, interferon. But then when Thalidomide became available, a lot of studies, randomized studies, were done with Thalidomide. And interestingly, as you can see here, in the majority of the trial, there was a benefit in event-free survival and also in 2 studies regarding overall survival. The major problem was that Thalidomide has some toxicity, especially neurotoxicity. So this was not the optimal drug. But at this time point, nothing was available. When the Bortezomib becomes available, there was a study also by the Hoven and the German group. And this is a bit busy slide, but I will just focus on this high-risk group. This is the 414 translocation and the 17p. So both is about 5 to 10% in multiple myeloma. And you should distinguish between receive Thalidomide as maintenance or Bortezomib as maintenance. And here in the high-risk arm, so in 414, the red one here is Thalidomide and this is Bortezomib. You can see there is, no, so the other way around. The red one is Bortezomib and the blue one is the Thalidomide. You can see there is a slightly benefit for the Bortezomib arm in the progression-free survival and in the overall survival. However, if you look to the p53, this is a very high-risk patient, you can see there was a significant benefit for using Bortezomib as maintenance therapy instead of Thalidomide. And this was also translated in an overall survival benefit for those patients who received Bortezomib. But then, as you may know, then came the lenalidomide into the field, and there were 2 or 3 large randomized trials. This is from the IFN again, and you can see with lenalidomide maintenance here in the French group, they used it only for 2 years. A significantly benefit in the progression-free survival, but this could not be translated in an overall survival because those patients, when they relapsed, had a worse outcome than those who did not receive lenalidomide maintenance therapy. The other study was a huge American study, same endpoint, but they used lenalidomide until treatment progressed, and they found also a survival benefit for those patients who received lenalidomide maintenance therapy until treatment progressed. So this led to the approval by the FDA and also by the EMA last year that lenalidomide is now approved as maintenance therapy after hydrotherapy for patients with multiple myeloma until treatment progress. So, and if there are conflicting data, so what is done usually is so-called a meta-analysis, and this was also done for these randomized studies with lenalidomide, and you can see at 7 years there was a survival benefit for the lenalidomide maintenance therapy, 62% versus 50%. In the beginning there was some concern about so-called secondary malignancies, but the malignancies were higher in the lenalidomide maintenance therapy, but because of the higher survival benefit, so this was offset by the risk of secondary malignancies. So when you did look in specific subgroups, and you can see nearly all patients benefit from the lenalidomide therapy, but if you look very carefully, is the more advanced disease, so this is the ISS3, did not benefit particularly from the lenalidomide maintenance therapy. And interesting also, if you go to a high-risk cytogenetic, yes, you can see also a high-risk cytogenetic, here defined also as p53 and 414 translocation, seems not to benefit especially from lenalidomide maintenance therapy. So this is still a matter of concern. So last, I would just brief how we can improve our results and what are the problems. And therefore we looked again in the EBMT database, more than 70,000 patients, and here you can see the major problem in multiple myeloma, and this is relapse. So at the end, the majority or nearly all patients who received an autograft will relapse. Maybe there are some exceptions, but the majority will relapse. You can see 80% after single, 74% after tandem. But even if you go for an allograft, which is a potential curative approach, you have more than 50% who will relapse here after 10 years. So quite a risk of relapse. So why do these patients relapse? And the problem is usually that even with transplantation, in the majority of the patients, you will not get to a very deep reduction of the tumor load. And this is so-called minimal residual disease, which is now becoming more and more in the clinic of multiple myeloma, because with the novel agents, you can achieve, at least in some patients, a very good and deep remission. So minimal residual disease, you might know from the acute leukemia, is acute lymphoblastic leukemia. It's many years a very important prognostic factor, and it's becoming also a very important factor for acute myeloid leukemia. And here's a large study investigating the role of minimal residual disease on progression-free and overall survival, and you can nicely see those patients who achieved a minimal residual disease negative status have a significant benefit in contrast to the MRD positive patient regarding progression-free and overall survival. So, and this is our experience when you have allo tandem. You can see only patients who really achieved MRD negativity, they are potentially cured. You can see this is more than 10 years, so there was no further relapse. While even if you have a mixed status of MRD, or if you are MRD positive, despite being in otherwise complete remission, so the risk of relapse is quite high. So what can we do and what is the option? So maybe this is good for this meeting because after autograft, but also after an allograft, you should use this as a platform and you should monitor this patient by MRD. This can be nicely done by fax analysis, so there are standardized methods by Euroflow, or you can use novel next generation sequencing methods. And then you have an option to start with cell therapy. So cell therapy is actually, because this is the meeting here, with donor lymphocyte infusion in after allograft, but you can use also vaccination or specific T cells after autograft, or more recently you can use CAR T cells. This is also an exciting new field of cellular therapy. Or you can use all the drugs we mentioned before, like IMiDs, proteasome inhibitors, or more recently also the monoclonal antibodies. That this is not only academic interest. I show you what we did in patients who have not a complete remission. This is only for the allograft patients, so we gave them prophylactic donor lymphocyte infusion to upgrade the remission. And you can nicely see that in about nearly 50% of the patient we could upgrade the remission, and in 25% we could achieve the molecular remission. And this has also some impact, so this is only the blue curves. This is therapeutic DLI, this is prophylactic DLI. You can see in these patients who have achieved a molecular remission in therapeutic, you can see that the survival is significantly higher than in those who did not achieve this remission. So at the end, I just want to summarize for you that autologous stem cell transplantation in multiple myeloma is still the treatment of choice for younger patients with newly diagnosed multiple myeloma patient in 2018. However, we should see what's coming up with the other drugs. The numbers of stem cell transplantation in Europe are still increasing despite the approval of novel and effective drugs. And also elderly patients with multiple myeloma may benefit from autograft. Allogeneic stem cell transplantation is a potential curative option, may be used in younger patients with high-risk cytogenetic or with an early relapse after an autograft. And modern transplant concept consisting of at least a 3-track induction therapy, high-dose therapy, consolidation, and maintenance therapy. But the main treatment goal for all of our patients should be to achieve a molecular remission, because this is the prerequisite for long-term freedom from disease and maybe also for cure. So I'd last want to thank the members of my department and especially the members of EBMT, mainly those who worked in the chronic malignancy working parties involved in multiple myeloma. And thank you for your attention. Thank you very much.